I've been seeing interstitial cystitis patients for over 30 years. I've seen more than 7,000 patients, and during that time frame I've done a lot of basic laboratory research as well as clinical research. And as the data emerged, I learned more and more about the disease. I no longer think about it like I did 30 years ago. It's basically an entirely new concept of what this disease is about. And what I think today is that there is one primary disease process that generates bladder symptoms in men and women less than 55 years of age. And that process is a dysfunctional bladder epithelium that allows the diffusion of the mineral potassium into the bladder wall, causing urgency, frequency, pain, and incontinence in any combination. A better title for this talk would be the etiology of symptoms in the lower urinary tract. What I think, if you want to be successful today in working with interstitial cystitis patients, is you have to recognize that they have the disease. 99% of the patients are misdiagnosed and given traditional diagnoses depending on what specialist they're seeing, such as the urologist versus the gynecologist. You have to remember that IC is a continuum. The classic definition of IC is not different than the earlier or intermittent versions which patients start out with. Classically, we only recognize the IC patient who has had the disease for anywhere from 10 to 30 years and has very severe symptomatology. But that's not the way it always was. Usually this disease begins with insidiously progressive frequency. So you have to remember that there's a continuum in this disease process. It's all about upregulation of the nerves of the bladder, the urgency fiber and the pain fiber. Urge fiber seems to upregulate first with a slowly progressive frequency. They can also have incontinence due to reactions to the potassium on the muscle of the bladder. This disease flares with sexual intercourse, usually the next day or two after they have sex in the beginning, but then sex starts to be painful, and or they have both, pain with sex and more symptom flares after sex. It flares with a menstrual cycle, and it flares with allergies. So the issues here are, if you're an 18-year-old female and you're having some discomfort after sex, and you're flaring with the menstrual cycle in terms of pelvic pain, what specialist will you see? You will wind up in the gynecologist's office, and you will be given a gynecologic diagnosis. The real issue is pain. Pain in interstitial cystitis is sometimes associated with bladder filling and emptying, but most of the time it's not. And that's the real issue. And the pain from the bladder, being a visceral organ, can be felt anywhere from the navel to the thighs, in the front or the back. This is what's confusing, because most of the time the pain is just present. It's in the labia or the scrotum or the lower abdomen or the vaginal area, whatever, and it's more constant in nature and not perceived by the patient to be from the bladder. And the other issue is you don't have to have pain to have interstitial cystitis. Most patients that are seen, at least in the urologist's office, that being me, start with this insidiously progressive frequency and may or may not develop pain cycles or may not develop pain at all. It's all about the epithelium. That's key in the pathogenesis of interstitial cystitis. This cartoon summarizes this concept. Basically, the bladder during the storage phase has to hold all the metabolites and solutes that have been cleared by the kidneys in the bladder lumen and not allow them to diffuse back into the bladder wall. And it can do so because the mucus lining the outer cells of the epithelium is a very impenetrable barrier that prevents the solutes from moving across the bladder wall. If that barrier is defective, then potassium is the real culprit here. It's very high concentrations in urine, up to 100 milliequivalents per liter, will allow for diffusion into the bladder wall where it will directly depolarize muscles and nerves and smooth muscle, so you can get pain, urgency, frequency, incontinence in any combination in these patients. What we discovered a long time ago was that you could destroy the bladder mucus in animals and humans, and you could replace it with an intravesical treatment of either heparin or pentosan polysulfate after just 35 to 40 minutes. That was an important step in our understanding of how we're going to approach the treatment of the disease, and that will be discussed later in the presentation. From the potassium hypothesis, we developed the potassium sensitivity test. It's a test that was a useful tool certainly for scientific purposes, and practically speaking, it's also a useful diagnostic tool. It's a simple test where we challenge people with potassium solution put into their bladder. We challenged them with a water of equal volume, and then we had a grading process to determine who was positive to the reaction and who was not. We did various iterations of this potassium testing, and I want to show you what we did with some control subjects. And what's shown here is a study where we gave potassium and sodium to people that were normal. And it was done in a blinded fashion, so neither the subject nor the person doing the study, administering the medications, would know what product they were putting into the bladder. In the first part of the slide, on the left side, you can see that the control, neither sodium nor potassium evoked any response. But after we destroyed the bladder mucus with protamine, and it's very effective at doing that, it's a highly charged cation which will stick to the very anionic bladder mucus and basically form a salt and destroy its activity. After the protamine, no real response to the sodium, but as seen in the yellow bar, there's a marked response to potassium. At the same time, they absorbed potassium where they did not do that previously. They were then given a heparin treatment for 40 minutes, and after the heparin treatment, you can see a significant reversal of the potassium effect, still not much in the way of a sodium effect. So this was important scientific data to validate the hypothesis that it was potassium that was causing the symptoms of interstitial cystitis, once there was a defective mucus. There are 3 slides here that summarize up to 35, and now it's over 40 patients in the global literature where people did potassium sensitivity testing and reported results. And it's very robust data, and I summarized it in this slide. And there have been over 3,100 people that have had a potassium test who have had interstitial cystitis, and the results are very uniform. Everybody has approximately an 80% response to potassium when it's put into the bladder. Controls, there have been 4 studies that have had controls, and the composite shows only 3 responded. That's only 1.3%. And urethral syndrome, which is a more milder phase of the disease where the symptoms are intermittent and the patients can go through periods with no symptoms, they're only 55% positive. So the bottom line is there's an 80% sensitivity and a 98.7% specificity at detecting abnormalities of the bladder epithelium using the potassium test. It's a very powerful scientific tool. Now we can go out to patient populations that have symptoms, do potassium testing, and see if they too have epithelial dysfunction. We looked at men with chronic prostatitis or chronic pelvic pain syndrome. They have the same symptoms that women do. They have dysuria, they have pain in the lower abdomen, they have testicular and scrotal pain analogous to vulvar pain and vulvodynia seen in the females. But basically they have the same symptoms. And when they had potassium sensitivity testing performed, there are 2 published studies that show respectively 83 and 84% of the patients are potassium sensitive. So prostatitis isn't a prostate disease, it's a bladder problem. Most of the patients have urgency frequency. That is a bladder symptom. And I don't know how that's missed. I don't know where the paradigm was created that created the whole concept that somehow the prostate causes these symptoms. Must have been 80 years ago and was propagated from one generation of urologists to the next. But it's all made up. It's just arbitrary definitions and diagnoses that were created all those many years ago. But the science says they have an abnormal bladder that's generating their symptoms. We looked at the presence of interstitial cystitis in gynecologic pelvic pain patients. They see over 15 million women chronically with pelvic pain, and they have their own paradigm for it. But if you look at our patients with pelvic pain and theirs, you can see both have dyspareunia, both have perimenstrual or menstrually associated flares, both flare during or after sex. They have pain anywhere from their navel to their thighs, and they have voiding symptoms. Ours do, that's why they're in the office, to see us, because of the voiding symptoms. Patients not perceiving their voiding symptoms as a problem, or not even thinking they have any voiding problems, believing 12 voids a day is normal, will see the gynecologist who will not find out that they have this problem. They won't ask them about it, and the patients aren't going to complain about it. So consequently, they will wind up with a gynecologic diagnosis that will be based on whatever artificial definition they have for their particular symptoms and fit it into their paradigm. So we had 4 gynecologists do potassium sensitivity testing on patients coming in to see them, and they took them serially, so they did not select patients. We had them screen their pelvic pain patients for potassium sensitivity. At the same time, give them a symptom questionnaire which called out bladder symptoms of frequency and urgency. But we did ask them how many times a day they voided. And what did we see? 81% had positive potassium tests, 84 had GU symptoms, that is 84%, which is identical to what we found in the urologic population. This is a major change in the paradigm for chronic pelvic pain in gynecology. And it's interesting because the gynecologists are taking very readily to it because they often don't know the source of the pain, and they have this test and data, and they can use this test to find out what is the source of the pain in their population. They also diagnose the patients as they normally would. Most of them received a diagnosis of pelvic pain because they didn't know where it was coming from. Not surprising. Then vulvodynia was the #1 or #2 diagnosis, along with dyspareunia, endometriosis, etc. Didn't make any difference what their clinical diagnosis was. All of them had positive potassium tests. This summarizes the potassium sensitivity test done in symptomatic populations. Interstitial cystitis, as reported, 80% are positive. Radiation cystitis, there were 5 reported, they were all positive, but the radiation damages the blood supply to the bladder, and then the epithelium becomes dysfunctional and potassium does the rest. BPH LUTs are positive in about 1 out of 6 patients that get urodynamic studies. That was done in 1 study. Prostatitis is 84% positive. Overactive bladder is in red because the study was done by a gynecologist, and 71% were positive. These are important results because there is this concept that somehow overactive bladder and IC cannot be the same disease. This data, scientific data, says they are. Normals are negative, and acute bacterial cystitis is positive, but negative 2 weeks later when they have lost their symptoms and the infection's gone. In summary, this is a unifying hypothesis for the generation of symptoms in the lower urinary tract. That is, you have epithelial dysfunction that results in increased urothelial permeability, and mucus is responsible for that permeability barrier. Once it's dysfunctional, potassium will diffuse into the bladder wall and cause symptoms of urgency, frequency, pain, and incontinence. And if you keep a nerve or muscle depolarized, it will die. So it will also injure tissue, leading to secondary inflammatory reactions, all of which is what we see. Interstitial cystitis, overactive bladder, chronic prostatitis, chronic pelvic pain syndrome, urethral syndrome, urgency frequency syndrome, recurrent UTIs, gynecologic chronic pelvic pain, vulvodynia, they're all potassium positive and all having the bladder that is generating their symptoms. And the irony is that interstitial cystitis is merely the very severe form of this disease where the patient's bladder is almost destroyed and they're incapacitated by their symptoms. The key to successful treatment is this. If you don't recognize that patients have IC and don't diagnose it, you won't be successful in their therapy. For example, consider overactive bladder patient who's not responding to therapy. Maybe it's interstitial cystitis, proceed accordingly. Patients with recurrent urinary tract infections who have repeatedly negative cultures, time to rethink it. They have interstitial cystitis, treat them appropriately. They'll get better. One useful tool in calling out the symptoms of interstitial cystitis is the pelvic pain urgency frequency questionnaire. This questionnaire was designed to call out the symptoms of interstitial cystitis. There are 3 questions on urgency, 3 questions on frequency, 3 questions on pelvic pain, not bladder pain, pelvic pain, and 2 on sexually associated symptom flares. So it calls out all of the symptoms. I think the frequency is a big issue because no one asked on any other questionnaire how often the people void. This Questionnaire was validated by the usual methods, normals with no symptoms versus symptomatic people, in test, retest, and more importantly, it was the first questionnaire that was also tested against a diagnostic, and that is the potassium sensitivity test. It's a large study. 334 patients were entered into the study, given the questionnaire, and had a potassium test, and 51 controls were entered and given a potassium test. Controls did not have any symptoms. They scored 0 to 1. They had negative potassium tests, all of them. But as the scores went up, as you can see along the abscissa, red representing patients seen by urologists, yellow gynecologists, they're all about the same, but as the scores go up, so does the incidence of having a positive potassium test. If you score 10, it's about 74%. If you score 15, it's about 79 to 80%. If you score 20, it's over 90%. Very useful tool for screening out the symptoms of IC and alerting you to the fact that they have this disease. That takes us to therapy. There are 3 basic principles to follow for therapy, critical principles. The first one is correct epithelial dysfunction. That's what the disease is all about. If you don't fix the epithelial dysfunction, you don't win the battle. And to do this, we have 2 drugs. We have pentasam polysulfate and we have heparin. Pentasam polysulfate, or Elmron, is an oral product. Heparin is not, and it has to be put into the bladder with a catheter. But you have to maintain the patients on one of the heparinoid therapies indefinitely if you want to be successful in therapy. Then inhibiting neurological activity is what we've done forever. We give them anticholinergics, antimuscarinics. We give them tricyclic antidepressants, even narcotics. There are a lot of drugs that we use to suppress the neurological hyperactivity, but remember, that's a response to the disease. It's not the cause. So you're shooting a messenger. It's fine to do this as long as you combine it with something that will correct the epithelial dysfunction. And lastly, you have to control the allergies, because histamine and allergies really drive the disease. Once you start releasing histamine around the body and in the bladder wall, it causes an epithelial dysfunction and the disease will flare. And that's going to be important therapy in about 70% of the patients. I wanted to show you some data on how important it is to maintain patients indefinitely on heparinoid therapy. You don't stop it. If you want to get better success with the patient, you can add more treatments, whether it be pelvic floor exercises or anything else that you're adding. You add it. You don't stop the basic drugs that will help fix the epithelial dysfunction. This is a study, a large study in 28 centers in North America that looked at about 350 patients with 3 different doses of pentasam polysulfate. And it was blinded. The study lasted 8 months. The important point about this study is that as you watch from 4 weeks to 32 weeks, there's a steady improvement in the patients as they stay on the drug. It gets to about 65% response rate, regardless of the dose, at about 8 months. It's important data, and it emphasizes the point. Pentasam or heparin do not directly treat the symptoms. They fix the problem, the bladder will heal, and this takes time. The dose that I usually use for pentasam polysulfate or Elmron is 200 milligrams twice a day. It's off-label. The labeling is 100 milligrams 3 times a day. That's fine. Hard to remember to take 3 pills a day. Best, if you're going to use 300 milligrams a day, have them take 2 in the morning and 1 at night, or vice versa, so that they don't have to take the middle of the day dose, which is one that's usually forgotten. And it's a relatively low dose, so you don't want them to miss that last pill. I also wanted to show you some data on what you can do to treat the allergies. I think that one of the most useful drugs in treating IC is hydroxyzine. It's Atarax is the old trade name. And this is double-blind data to show that when you combine Atarax or hydroxyzine and pentasam polysulfate, you have significantly more improvement over placebo, and that it's even numerically better than pentasam alone, which is also better than placebo. So the dose of hydroxyzine that we recommend is 10 to 25 milligrams initially, at least 1 hour before bedtime. because it's sedating, and if they don't take it at least 1 hour before bedtime, then they will be fatigued the next morning and they won't take the medication. It works better after they're on the drug for 1 to 3 months and continues to improve. They usually need less over time, but during the allergy seasons they may need it doubled and tripled. But if they take it all year long, the sedating effects are minimal and they have better effect on the mast cells at blocking the production of histamine. This is the biggest breakthrough that we have had for treating the acute symptoms of interstitial cystitis. We had nothing prior to this, maybe narcotics, and they're certainly not a good option for the patients. They work not as well, they're addicting, and they cause upregulation of the nerve fibers. But lidocaine comes as lidocaine hydrochloride, and it's protonated with hydrochloric acid from its free base form. Its free base form is not soluble in water, so that's why it's protonated. But when it's protonated, it won't go through lipid membranes. You can trade it off by alkalinizing it. If you raise the pH to 7.1 or higher, then you shift the equation so that there's more of the drug in the free base form that will go through the lipid membrane. Anesthesiologists have been doing this routinely for 20 years with their local anesthetics by adding a little bit of bicarbonate to the lidocaine because it sets up more quickly in the nerve endings and gives a more profound block. The other drug that we add to this is heparin, because we know from animal studies, we know from human studies that it will coat the defective epithelial wall and restore the permeability barrier. So what we do is we use the lidocaine to anesthetize the nerves, and then we add the heparin because it will coat the bladder wall to block the passage of new potassium into the bladder wall once the lidocaine wears off, and it does seem to potentiate the activity substantially. When this mixture was studied in a double-blind trial that was done in several sites in North America, there were 18 subjects entered, and it was a complete crossover study so that every subject got drug and every subject got placebo in random orders. Some got drug first, some got placebo first. At the end of the dosing and the next day when data were tabulated, the global assessment response, defined as what percent you're better, and when patients declare I'm at least 50% better, we consider that a positive response. That response was 50% for drug and 13% placebo. Placebo rate's about typical. But this is the best separation of drug versus placebo in any randomized trial that was double-blinded on interstitial cystitis. The average pain also dropped significantly. In the patients, it was 38% versus 17% in the placebo group over a 12-hour period, and urgency similarly was 35% better versus 13% better. There's one other point I would like to make about the mixture. Lidocaine alone might anesthetize the bladder for about an hour, but the median response published in the literature was about 8 hours, with half the patients having relief up to 24 hours. And we think the lidocaine downregulated the sensory nerves in addition to anesthetizing them. And with the heparin in there to coat, it reduced the provocation from fresh potassium.